We can think about obtaining data on variables that may be driving disparities in health outcomes. So, whether this is systemic, structural, or environmental variables, and focus on the social determinants of health screener. The learning objectives, just understanding the role of social determinants in health disparities research, think about limitations of using screening results in research, and then describing opportunities for future research in this area. So, just thinking about health disparities and how they're driven by these social and environmental factors, I thought this chart was helpful. And we're really going to focus on those social factors that are present within our Nemours screener, which I'll talk more about. So, how can we design research questions to really capture the appropriate variables, or in some cases, confounders that might be contributing to whatever outcome or exposure potentially that you're looking at? And so, really, in health disparities research, it's not only thinking about the factors or exposures that could be contributing to the disparity, but also thinking about ways to improve the disparity. So, for example, if you're trying to understand factors contributing to disparities, you may think about looking at the impact of housing code violations based on zip code and how this contributes to differences in ED utilization, with ED utilization being sort of the proxy for health disparities. But if you were to focus on a question that is looking more at interventions and ways to improve this disparity in health outcome, you may look at how referral to medical legal services to address housing code violations would help improve disparities in ED utilization. But the question is sort of, where do you get this data? And I'm going to go through this briefly. If anyone has more questions, they can reach out to me. But thinking about our EHR, of course, you can get information like age, gender identity, race, ethnicity, which there are potentially barriers to how we use that based on how race, ethnicity is collected from families. You can use insurance status as a proxy for socioeconomic status, thinking about language, zip code, and address. Disability and medical complexity score, and of course, the social determinant screening results. Secondary healthcare databases, like the Pediatric Health Information System, do contain some of this information. For example, FIS integrates the Child Opportunity Index. And then you can also think about integrating geocoded sources of secondary data, like I mentioned, the COI, Area Deprivation Index, Social Vulnerability Index, or census data through the American Community Survey. But focusing on social determinants of health, so I think covering definitions is important because this is really used to inform study design and how you're using the screening results. So social determinants are really thinking about community level social determinants. It's sort of a catch-all term, but really social risk factor screening is what hospitals are using when they do social determinants of health screening. So these are those individual level adverse social determinants that are often measured and validated by screening tools. Social needs, on the other hand, are much more family centered. So it's what the family feels we need to intervene on to improve their health. And this differentiation is important because it's thinking about the difference between risk factors, which is a positive screen on a screening tool, versus social need, which is whether or not the family feels they need assistance for that positive screen. This is Nemours Screener, so you can reference this if you're curious as to what questions we ask. And there's a really nice report that was done by our National Center of Policy and Prevention that just came out in 2023 that summarizes the approach that Nemours took to develop this tool. It's basically a QI process over multiple years. This screening tool is offered to all Nemours primary care patients at their well child checks. It's completed differently at each clinic based on the provider's preferences and what works best into the workflow. So it might sometimes be on paper, sometimes it's integrated into the Nemours app, and sometimes it's integrated on Epic. But I do want to highlight two important questions. So the first one is, would you like to complete the form? So families can decline completing the form. And then the last question is, are you interested in receiving assistance from Nemours about other professional resources to meet these needs? So again, this is that differentiation. A family may identify a housing need, but they may not feel that they need resources to address this need in order to improve their health or well-being. So Nemours screens in the areas of utility, housing, both housing conditions and stability, transportation, social support, violence, neighborhood conditions, health literacy, legal concerns, and food insecurity, and financial insecurity. And this gets pulled into Epic. So when you're doing research, it can very easily be pulled from Epic. Our top needs are internet, neighborhood safety, and food insecurity. So thinking about some of these research limitations, if say you wanted to use these social determinant screening results. So the first and I think biggest one is that although there are validated social determinant screening tools, Nemours screening tool is not validated. But this sort of gets into the question of what it means to validate a social determinant screening tool. If, for example, you're using a mammogram to screen for breast cancer, you're doing that because you're going to take an actionable step. It's going to inform your management. But if you use a social determinant screening tool, sort of the question is, well, what is your actionable step, especially if the family doesn't feel that they need resources or the resources aren't available in the community? So I think even though it's not validated, it's potentially useful as long as that limitation is acknowledged in your discussion. The screening results are potentially more useful to inform patient care on an individual level, and there are some concerns that the screening results don't fully represent population level needs because of a few points I've highlighted below. Only 35% of Nemours primary care patients were offered a screen, and these are a little bit older results. That number has expanded more recently. And then of the screens that the family actually completed, only 14% identified at least one, I'm sorry, it should say resource, but at least one need. And then only 36% of families desired resources. So thinking about how that may interpret your results versus whether you want to focus on only pulling patients who have a social determinant screen completed. There's disparities potentially related to the screening process itself, and that the screen is only done at Nemours primary care well visits. So if a family is not compliant with their well visit, they're not being screened, and these may actually be the patients that are at highest risk of health disparities. The transient nature of social determinants is important. So although a family identifies a social determinant at one point in time, that can very rapidly change. And the role of the screening process for research versus QI and operations, which the latter is really what we're using it for currently. So just some quick IRB considerations. Our IRB currently is non-research, so quality improvement. Retrospective studies to use this data may require a waiver of consent. You have to think about if you're using geospatial analysis, how this may have implications for PHI, depending on the size of the geographic region that you're looking at. And then prospective studies may require consent in conjunction with the screening process. If you approach VBSO data and analytics to obtain this data, they are going to require either an IRB determination or a Quality Research Council determination as non-research. So the last slide is just thinking about future areas of study. So if you are interested in engaging more in specifically social determinants of health research, these are sort of the areas where there are literature gaps. So first, the role of screening outside of the healthcare setting. So looking at how screeners function in, say, school-based health centers or even community centers. There really is a need to increase the evidence base surrounding interventions to address social determinants. And I've listed a few resources there. OASIS is a framework for thinking about interventions research related to social needs. And then SIREN, the Social Interventions Research and Evaluation Network, contains a lot of resources related to this topic. And then also thinking about the impact of these interventions on health outcomes, well-being, mental health, and healthcare costs. A lot of the studies look at whether interventions address the social need, but don't necessarily link that back to an improved health outcome. And then also the impact of programs on more patient-centered outcomes like school absenteeism, aligning community resources with social need, and then also thinking about how this research can be used to engage with communities and inform policy change. So I'm going to go ahead and stop there for the sake of time. So I'll stop sharing.